Hi, my name's Jennifer Jager. I'm going to be talking to you about STABLE. That's a method for preparing for resuscitation, stabilization, and transport of sick and or preterm infants. I'm the coordinator of our NICU Graduate Developmental Care Program. I'm a charge nurse in our Level 3 NICU. I'm a neonatal outreach program educator, a member of our transport team, and also an instructor of NRP, PALS, and STABLE. So the goal of STABLE is to provide stabilization activities that are critical for the post-resuscitation and pre-transport care of sick infants. It's a mnemonic that stands for sugar and safe care, temperature, airway, blood pressure, lab work, and emotional support. STABLE follows the basics first. So it begins after ABCs, NRP, and PALS or PALS have been provided to stabilize your patient. The S in STABLE stands for sugar and safe care. An important point to know is that you should not feed an infant who is sick. They're at an increased risk for delayed gastric emptying. They're at risk for aspiration. They have poor swallow-breathe coordination, so if you give them a bottle or let them go to breasts, they're likely going to aspirate. They may have abdominal distension. If they are hypoxic or hypotensive, that may result in reduced blood flow to the intestines. And it may even be necessary to withdraw a recent feed from the stomach if that's reported to you. Also, if a bowel obstruction is suspected, you should decompress the stomach. The proper way to decompress the stomach or withdraw the contents of a recent feeding is to use a feeding tube. They come in various sizes, whatever you might have, you can probably make work. So you measure from the corner of the baby's nose, or if you're going to go in his mouth, from the corner of his lip to his ear with the feeding tube, and then you're going to find the point halfway between his xiphoid process and his belly button, and you're going to measure that. I get a 24 on this baby, and then I'm going to insert the feeding tube down to the 24 and just slide that down. When you get to the 24, you can use a tegaderm or a little piece of tape to adhere it to his cheek, and then you can attach a syringe and pull out any air for a round stomach or withdraw any feeding and discard that. You can either leave the feeding tube in to decompress later, or you can go ahead and withdraw it. Sugar and safe care, again, we're going to provide glucose via IV fluids. The most successful IV sites for children and infants are their hands, feet, and scalp. If those attempts are unsuccessful, you want to use the intraosseous site. An IO drill is appropriate to use in the newborn and infant patient. Some IV pointers: you want to have at least 2 people present to start an IV on a child or an infant. Provide them a pacifier for comfort if that's something that they usually enjoy. Swaddle and papoose all infant and children, and then you want to move slowly as you're adjusting the angiocath because the blood return is going to be much slower on children than it is adults. This is one way to swaddle a baby so that you have an arm out that you might attempt to start an IV in his hand. If I wanted to attempt an IV start in a scalp, I might swaddle him completely. This is going to help him feel contained. It's going to keep him warm. It's going to make him feel secure. And it also keeps him from moving too much. If you would like to start an IV in the scalp, babies have excellent scalp veins. You can use like an office rubber band to put it around the eyebrow to help your vessels stand up. And then you should point the catheter down towards the heart. So they frequently have a big one behind their ears, so I would go at this angle. They usually have one right in the center of the forehead, and again, you would go down. So any one you find, you'd be pointing down towards the heart would be the proper placement. Newborns that are going to be at risk for hypoglycemia, babies that are preterm, anything less than 37 weeks is considered preterm, so you'd want to be prepared for that. A baby that's small for gestational age, large for gestational age, those babies are at risk for a low blood sugar. If you're unaware of what might qualify as SGA or LGA, I frequently use Google on my phone to have information quick at hand. Babies for an infant of a diabetic mother and any sick infant is going to use more glucose than normal. Signs and symptoms of hypoglycemia include an abnormal cry, a low temp, tremors, irritability, lethargy, tachypnea, cyanosis, poor sucking coordination. They're going to be sweaty, jittery, hypotonia, seizures, and maybe even apnea. Stable recommends the goal of therapy to be 50 to 110, and this is a little higher than the American Academy of Pediatrics, but their goal is babies that are staying in the same facility with their mother. Stable's preparing for a baby who is post-resuscitation and pre-transport to another facility, another floor, those kind of things. So you want the goal to be, you want the sugar to be a little higher. Initial IV fluid management of a sick infant, because we've established that we shouldn't feed them, so we can't raise their sugar that way. D10 at 80 milliliters per kilo per day, and you always infuse on an infant or a newborn using a pump. So D10 is your fluid of choice. To treat a glucose less than 50, you want to give a D10 bolus. So 2 cc's per kilo of a D10 bolus at 1 milliliter per minute. So we have an example of 4 kilogram baby with a blood sugar of 38. We would initially start their IV of D10, and we've done the math, and that means we're going to set our pump at 13 cc's per hour. In addition to that, we're also going to piggyback in a little bolus of 8 cc's of D10, and it's going to run over 8 minutes. 15 to 30 minutes after that bolus is done, and you can again use your phone to set a timer, you want to recheck the glucose. If it is again less than 50, you want to repeat the 2 cc per kilo bolus. So we're going to give another 8 cc's in our example, and we're going to run that over 8 minutes, and we're going to do the math and increase our infusion to 100 cc's per kilo per day. We're going to set our timer again, recheck in 15 to 30 minutes after that bolus is complete. If that sugar is still less than 50, repeat your bolus. You want to increase your infusion to 120 cc's per kilo, or you can increase the dextrose concentration to D12.5 and run that at maintain it 100 cc's per kilo per day. It is possible to go up to D15, but no, the highest concentration for a peripheral site is D12.5. If you're going higher than that, that will require a central line. We're moving on to T for temperature. Hypothermia is a preventable condition, so we should make sure we're doing all we can to prevent hypothermia. It has a well-documented impact on morbidity and mortality. Your baby's chances of dying are much greater if they are cold at any point, and this is especially true for premature infants. Maintaining that normal temperature is a priority whether the baby's well or sick. Things that put your patient at risk, increased risk for hypothermia, is prematurity, a low birth weight, infants that are undergoing a prolonged resuscitation because you're blowing cold oxygen flow directly into the heart and lungs, where it's going to cool the blood that's being pumped all over the body. And also infants who become acutely ill. People at risk, infants at risk for hypothermia include premature babies, low birth weight babies, prolonged resuscitation, especially if hypoxic, for the reasons I said before, babies who are acutely ill with infection, cardiac, surgical problems, and then babies who have decreased activity or hypotonic. They're not moving around, they're not staying flexed to have that muscle activity that's going to create heat. What's the normal temperature? In Celsius is 36.5 to 37.5, and in Fahrenheit, 97.7 to 99.5. That's your goal. So proper thermometer placement, axillary is the best place to take a temperature. Ways that you can maintain or increase temperature is placing the baby skin to skin. And as you can see in the picture, it's important the baby goes vertical on mom's chest between her breasts. The baby should have at most a diaper on, maybe a hat. Mom needs to be bare chested with no shirt or bralette, so that baby's chest is against mom's chest. You can use a radiant warmer. Remember that on a radiant warmer, the temp probe is going to be placed over the liver, and you want to set that to servo control or baby mode. A good starting place is 36.5, but you want to check the baby's temperature with an axillary thermometer frequently, every 15 to 30 minutes while they're on the warmer. And they can only be wearing a diaper on the radiant warmer. It needs to allow the heat to get to their skin in order to heat them properly. So no clothes when they're on the radiant warmer. They can wear a hat. Swaddling, like the baby in the bottom left, is appropriate. When they're swaddled, the warmer should not be on, but keeping the baby in a flex position keeps them warm, and then layers of blankets also is going to help keep heat in. Also know that a baby who's prone and flexed is going to keep them warmer. You can put them prone and flexed on a radiant warmer, but then you would need to put your heart, your gold heart or your temp probe up towards the radiant warmer where it can pick up skin temperature on the side that's facing the heat. So again, a reminder, when the baby's on the radiant warmer, no clothes. They can wear a diaper, and a hat is a good idea. You want to make sure the baby's under the heater. Sometimes during resuscitation and procedures, they get pulled towards the foot and their head is not under the heat source anymore. So keep them under the heater, centered, and the temp probe goes over the liver area where you're going to have a lot of blood flow to get a pretty good core temperature. You want to set it to baby mode or servo control. 36.5 is a good starting point. And remember, no clothes when they're under the radiant warmer. Give them a hat. So cute little picture. A hat is always a good idea in a newborn or a baby who's in a facility where it may be cooler. If you have a baby who was born in your facility, you want to make sure you get wet blankets from the amniotic fluid away from them. So dry them off, get the wet blankets. Even an infant who's just in your facility because they're sick, maybe they've spit up or the diapers leaked on the blanket, you want to get wet linens away from them. That's going to bring their temperature down. Moving on to airway, and that's going to be covered in another segment by our respiratory therapist extraordinaire, Jimmy McCann. We're moving on to the B in stable. That stands for blood pressure. So here we're going to talk about shock. It's just to remind you to assess blood pressure. For cells to survive and function, they need oxygen. So there's a state of shock when there's inadequate tissue perfusion and oxygen delivery to all the vital organs. There's two phases of shock, compensated and uncompensated. In compensated, blood flow is diverted from non-vital organs. So as we mentioned before, the intestines may not be getting as much blood. The skin may not be getting as much blood. In this state, blood pressure and blood flow to the vital organs is maintained, so heart, lungs, and brain. If this shock isn't quickly recognized and reversed, it leads to anaerobic metabolism that then leads to lactic acid accumulation. It's going to cause the pH in your blood gas to become acidotic. That's going to lead to cardiac output and eventually death. So you must reverse the stages of shock. Uncompensated shock is when the baby's moved to a point where their normal blood pressure is no longer maintained. Physical exam findings that are indicative of shock. Some of these are the same things we saw on a baby with low blood sugar. Tachypnea, apnea, cyanosis or DSATs, bradycardia, which in an infant newborn is less than 100 beats per minute. A blood pressure that's too low. Poor perfusion, where their cap refill is greater than 3 seconds. On newborns and infants, you're going to check capillary refill in the middle of their forehead or in the center of their sternum or on the top of their tibia. You're not checking out at their fingernail beds. You're going to watch for cool skin, decreased urine output, increased work of breathing. They may have gasping if it's severe. They have pale or white skin color. They may have tachycardia, where their heart is working fast to compensate. Weak peripheral pulses. When you look at the chest x-ray, the heart's enlarged, and mottled skin is frequently seen. So there's 3 types of shock, and what type of shock you think you may be dealing with helps determine treatment. So you see in the picture, this baby is pale, they have low tone. If the picture were a little more clear, maybe they have mottling. And you see, obviously, there's intubated, so level of consciousness, work of breathing is not maintainable right now for the baby. The 3 types of shock are hypovolemia, cardiogenic, and septic. In hypovolemic shock, you have low circulating blood volume. So there's several causes listed there, and if the baby's born in your facility or was born shortly before they arrived, the history from mom may give you a clue that that's the cause of the shock. So a lot of moms will know if they have a previa and can tell you that. Maybe if you were present for the delivery, you know if it was an abruption, brain scalp or lung hemorrhage. In the picture, you see a twin-to-twin transfusion where there's been some problem with the blood flow between the placenta and the baby. So one baby received all the blood and the other didn't get so much. An umbilical cord accident, that the cord may be compressed somehow during delivery. That's different than an umbilical cord injury where maybe the cord was torn and the baby bled from there. Cardiogenic shock, that's when the heart muscle functions poorly. That can happen with an intrapartum or a postpartum asphyxia. And again, that could be a cord accident of sorts. Hypoxia or metabolic acidosis, that can occur with infection, severe respiratory distress, very low sugar. In arrhythmias, which most commonly you're going to see a kind of congenital SVT or a congenital heart disease. Septic or distributive shock is a 3rd kind. In that situation, you're going to have loss of vascular integrity. So the blood vessels in the baby have lost their tone and they leak blood into the tissue beds. There's going to be poor muscle contractility, which leads to poor tissue perfusion and oxygenation. These infants need fluid resuscitation and blood pressure meds. Treatment of shock, the number 1 is to identify and figure out its cause or causes if there's multiple. And then the next thing is to correct any underlying problems or related problems that are impairing the heart function. Treatment of hypovolemic shock. So you want to improve the circulating blood volume. If you know that there was no acute blood loss, but your baby appears shocky, you want to administer 10 cc's per kilo of saline over 15 to 30 minutes. So you want to do that on a pump. If you know there was an acute blood loss, there was an abruption, there was previa, the cord clamp came off and the baby lost blood through their umbilical cord, you want to administer packed red blood cells or whole blood, 10 cc's per kilo over 30 minutes to 2 hours. If you're dealing with cardiogenic shock, you want to correct the underlying problems. So hypoxemia, give them oxygen, hypoglycemia, normalize their sugar, hypothermia, get their temperature appropriate, hypotension, give them fluids, acidosis, arrhythmias, if that needs to be corrected, infection, you want to start treatment early, and if the baby's experiencing any electrolyte imbalances, you want to correct those. Treatment of septic shock, mini fluid boluses. So you're going to be repeating that 10 cc's per kilo. You're going to reassess and then administer another bolus if the baby's signs of shock haven't improved. Dopamine is also good treatment for septic shock, and you want to optimize oxygenation and ventilation. So assuming you have a transport team coming, you may consult with the expert to get advice on whether your baby should be changed from nasal cannula to CPAP or CPAP to intubated, and go from there with that information. L is for lab work. So you may need to be doing some lab work. Neonatal infection is devastating to an immunological immature baby. Their immune system is very immature, and it puts them at increased risk for acquiring and succumbing to infection, and it happens fast in a matter of hours. The signs of sepsis may range from subtle and nonspecific to mistakenly apparent. Best practice, give antibiotics to any neonate has any signs of infection. So your subtle, nonspecific signs, which these are strikingly similar to some of the other clinical findings that we've seen: respiratory distress, apnea, tachypnea, tachycardia, and foreskin perfusion. And that's a great example in the picture of modeling in a newborn. Clinical signs of sepsis, all those, like I said, we've seen before. Temp instability, frequently newborns who are septic are cold instead of running a fever, so be aware of that. Again, we've talked about tachycardia, bradycardia. They might be feeding, they quit eating at home, they threw up all their feedings. All these things we frequently see. And then obvious signs of infection, maybe there's blisters or you see some soft tissue, swelling, redness, maybe from their recent circ, maybe from their umbilical stump. Some lab evaluation that's important to have and can be started prior to transport: a CBC with a differential, a blood culture, a blood sugar, and a blood gas. So blood count, blood culture, blood sugar, blood gas. Antibiotics started early are imperative. Of course, you want to get your blood culture first. Recommended antibiotics that will cover a huge percentage of the infections that affect neonates is ampicillin and gentamicin. The doses are there. AMP is 50 milligrams per kilo over 5 minutes every 12 hours, and the gent is 4 to 5 milligrams per kilo per dose. And that interval is every 24 to 48 hours, depending on the baby's gestational age. So you can give the first dose and then let the experts decide what the interval will be. E in stable stands for emotional support. A sick or a preterm infant is a major crisis and shock for families. They all have pictured in their mind a perfect birth and a perfect baby. And when that isn't happening, it is very difficult for them. Some of the emotions you may see: a sense of failure. Moms feel their bodies have failed them if the baby's born early or there's a cord accident of some sort. They may be quiet and fearful and sad, or you may see someone who's angry. So be prepared for anything. When the transport team arrives, frequently the parent's not able to go on transport with their baby. So it might be good for you to accompany the team and listen to an explanation of the condition so that you can repeat that to the parents or help explain it further. You want to expect them to have a hard time recalling the information, and you may have to repeatedly explain that. If you have any material or illustrations to give them, and then it's good to help them think of questions, write down questions. Sometimes they're just too distraught to think clearly. After the transport leaves, if you are a delivering facility and you're keeping the mom with you, you want to encourage and assist with pumping. You want to facilitate communication between the parents and the staff caring for the baby. So getting phone numbers or maybe even calling yourself to check on the baby to make sure that they arrive safely and let the parents know that. If you have social services available at your facility that can assist with transportation, gas cards, cabs, maybe some meals or lodging if possible, just to facilitate, this is likely something they were not expecting at all. It becomes an emotional and a financial burden. So in conclusion, you want to address all the points of stable post-resuscitation and in that pre-transport time with your infant to improve all your outcomes. Thank you very much.